Hello, welcome. We hope you're enjoying this practical ophthalmology series. This is lecture number 3. Today we're going to be discussing the basic principles of trauma, discussing the setting of ophthalmology. The content today, we're going to talk about ruptured globes, orbital fractures, chemical burns, as well as corneal abrasions and ulcers. So let's start things off with a trauma. So you're told about a 35-year-old white male who presents to the emergency room for evaluation after suffering a penetrating eye injury while nailing shingles onto his roof. You're the ED resident. Which of the following steps are reasonable to initiate before the ophthalmology service arrives for this guy's eye? So take a moment to look over the answer options. Pause the video for a moment and make a selection. Okay, if you chose answer B, you would have chosen the correct answer. You're going to want to get a CT scan of the orbits without contrast to evaluate the globe itself, see if there's any foreign body inside the eye. You're going to want to start vancomycin and moxifloxacin IV. Moxifloxacin has been shown to penetrate the vitreous well, so that's the reason why for that selection. You're also going to want to place a Fox shield. The other answers are kind of not correct. Starting Vigamox drops every 2 hours isn't a bad thought, but you're not going to want to perform an ultrasound to see if the retina is attached. That's a little bit above what we would expect of you in this setting. And then putting erythromycin ointment on the patient is not a good idea. You don't want to be messing with the eye when you see a nail sticking out of it until the ophthalmology team can get there. And then leaving the patient alone and letting the ophthalmology do the work. You know, we're happy to do whatever we need to, but if you can get the patient into the CT scanner and get the antibiotics going, you're going to be doing us a service. So, an open globe. The clinical definition of an open globe is a full thickness wound of the cornea or sclera. It can be due to a blunt force injury that leads to just a rupture itself, or it can be due to a penetrating injury, as we saw with the gentleman with the nail previously. The signs and symptoms. Now, these are some things that you're really going to want to know if you're working in the emergency room to see how serious of an injury the patient has. There can be reduced vision, ocular pain, a hyphema, which is just blood collecting in the anterior chamber of the eye, iris deformities, such as seen here. This is an iridodialysis, which is where the iris inserts from its normal anatomical position. Or you can also see lens disruption or vitreous hemorrhage. A couple of the other photos here to mention. This is uveal tissue prolapsing through a conjunctival and also possibly cornea laceration. Not something you're going to want to see. And then a CT scan that we talked about, you're going to want to get that, can show just gross deformity of the globe itself and can demonstrate this flat tire sign. Again, the globe looks kind of deflated, and it looks like here you see signs of a foreign body, possibly a bullet, lodged in the back of the eye. So the management, as we mentioned, you're going to want to get a CT scan of the orbits without contrast to get it done quickly. You're going to want to keep the patient NPO because they're going to need emergency surgery. You're going to want to put a Fox shield to keep anyone from messing with the eye, keeping them from touching it itself. These patients are going to be nauseous and they'll need pain control. So you're going to get Zofran and possibly get some morphine going for them, and get the antibiotics on board like we had talked about, and call ophthalmology. If you're interested in more about the prognosis of your patient when they come with an open globe, well, Dr. Barr, who has been with U of L Department of Ophthalmology for over 30 years, wrote one of the commonly cited papers on the prognosis for a patient with an open globe. And some of the most pertinent takeaways from that article are the visual acuity at the time of presentation is very important. Absence of hyphema is promising. Absence of uveal prolapse or vitreous hemorrhage is promising for whether or not they ended up needing a enucleation. And the size of the laceration itself is important. He was also able to demonstrate in that paper that a delay of up to 36 hours for repair didn't necessarily show a reduction in the overall outcome for the eye. Now, that's to be taken with a grain of salt. If someone has a nail lodged in their eye, anytime that eye is moving around, it can cause more intraocular damage, and we need to get them to the operating room as soon as possible. Okay, moving on from open globe, let's talk about orbital fracture. Certainly something we see quite a bit at the University of Louisville emergency room. You're told about a 45-year-old white male who presents to the emergency department after being assaulted with a closed fist while leaving a spirited football game. He has a very swollen right eye and is complaining of blurry vision. The ER orders a CT scan of the face to work him up for a suspected fracture. Which of the following answer choices correctly identifies an indication for emergent surgical correction? So looking at the CT scan, we see a right orbital floor fracture involving the maxillary sinus, and we see a little bit of herniation of fat tissue. We're given some choices here. So pause the video, review the answers, and come up with the best selection you think. If you chose answer B, you chose the correct answer. Complete limitation of upward gaze in the right eye with associated orbital floor fracture. And that's what we talk about when we talk about entrapment. Entrapment is a clinical diagnosis. You can't make that diagnosis based on radiology alone, although radiology certainly is a helpful piece of the puzzle. And what's going on in entrapment is basically, in most cases, it's of the inferior rectus muscle through this little, it's called a trapdoor fracture, where the inferior rectus muscle slips in between these two bony segments and is continuously contracted. And as it's continuously contracted, if that happens over a long period of time, that muscle will wear out and become necrotic, and the patient can have long-term issues. It depends on what literature studies you want to cite, but on how emergently it needs to be repaired. But certainly it's something that needs to be addressed within 24 to 72 hours, and it's not something to be taken lightly in trauma. The other options really aren't correct. Intermittent double vision, you can get that from swelling. A hyphema, we saw that before. Patients can get that when they have a bad trauma, but doesn't necessarily mean that they're entrapped or need emergency repair. And then their vision limit is 2200. That doesn't really make sense as an answer choice. So orbital fractures, let's talk about some of the things you need to consider when evaluating a patient with this. The range of motion for the eyes and all the different gazes is important to note and document in your chart. As we mentioned, complete restriction of motility can be a sign of entrapment, and it's something you need to think about. You can have some mild restriction in gazes based on just swelling in general, but you never want to see a complete lack of movement in any of those 6 principal directions. Numbing around the inferior part of the orbital rim can be a sign of damage to the infraorbital nerve and sign of an orbital fracture, even if you don't have a CT scan to demonstrate it yet. One thing to keep in mind is if the patient has extensive pain and a reduction in vision, that can be suggestive of a retrobulbar hematoma. We're going to talk a little bit more about that in a moment, but it's something to remember. Then ecchymosis and edema of the eyelid itself is something that you're going to want to note on your chart. So ecchymosis is just a ophthalmology term for swelling, or is swelling of the surrounding soft tissue. There are a few indications for repair that are generally cited, although there's some debate on complete agreement on all these. But things for you to keep in mind for learning: if the patient has double vision with limitation in up gaze or down gaze within 30 degrees of the primary position, that's someone who's usually going to get a repair. If they have inophthalmos that exceeds over 2 millimeters, if they have a large floor fracture of greater than 50%, and if they have a lateral zygoma fracture, then they're going to get, and they have pain opening their jaw, then they're going to go ahead and get a repair done as well. So let's take a look at some of these photos. Inophthalmos is just basically the sinking in of the eye itself back into the orbit. You can appreciate that here in this photo, how the eye is kind of sunken back in compared to the left eye. The retrobulbar hematoma, which you can appreciate, is conjunctival chemosis, which is swelling of the conjunctiva, and this eye is proptotic. Now this is the same eye. CT scan shows an intraorbital hematoma. It also shows some proptosis. In general, the eye is kind of sticking out, and some globe tinting. You'll appreciate that this eye has more of a basketball shape as opposed to the normal kind of pear shape that the globe usually has. When this happens, it's a sign of orbital compartment syndrome. And orbital compartment syndrome is a scary thing for any ophthalmologist. It can mean that the patient needs an emergent lateral canthotomy and cantholysis. And what that is a procedure where the pressure from the blood within the orbit is causing irreversible damage and squeezing on the optic nerve itself and causing a lot of trouble for the patient. So what ophthalmologists do, and ER staff are trained about on this as well, is that something called a lateral canthotomy and cantholysis. And if you'd like to learn a little bit more of that, I will provide the link for you. But what you're doing is cutting the lateral canthal tendon out to create more space for the eye to relieve the pressure that's being exerted upon it. What are some other key tips about orbital fractures to keep in mind? Well, entrapment is a clinical diagnosis. We mentioned that you can't just call this entrapment without evaluating the patient himself. You want to keep in mind the oculocardiac reflex. There's complex interactions between the trigeminal nerves and the vagus nerve. So if a patient is entrapped, they're very likely to have bradycardia, nausea, vomiting, and syncope when you're evaluating them and asking to look in the various gazes. This is an example of entrapment of the left inferior rectus. This patient is trying to look up and is having a tough time. You would expect him to have bradycardia, nausea, and tons of pain. And then orbital root fractures typically require neurosurgery input to ensure that there's no signs of cerebral spinal fluid leak present. That's something to keep in mind as well. So let's move on to another subject, chemical eye injuries. And let's start with a question. You're told about a 4-year-old child who presents at Coast Children's Hospital after his mother found him crying with a Tide Pod that had exploded in his left eye. You page ophthalmology for guidance, but the resident reports that she is currently performing canthotomy and cantholysis at U of L for a retrobulbar hematoma, something we just talked about, an emergency procedure. What is the recommended next step? Take a moment, look over the options, pause the video, and let me know what you think. So if you chose option C, you chose the correct answer. You're going to want to know the pH initially by checking with the paper that's provided in ER departments. You're going to want to irrigate with 1.5 liters of normal saline for 20 minutes. If you don't have normal saline, lactated ringers works practically the same as well. And then you're going to want to check the pH again to see where you're at and to see if you need to irrigate more. The other answers are incorrect. You're not going to want to mess with counterbalancing the alkali solution. We all know that alkali solutions are more dangerous to the eye itself in chemical injuries because they are able to penetrate the eye itself better. So chemical eye injuries, the most common agents that we see in ophthalmology are ammonia, sodium hydroxide, and lime solutions. These are all commonly found in cleaning products. And the pathophysiology revolves around the necrosis of the conjunctiva and corneal epithelium with disruption and occlusion of the limbal vasculature. basically you have a toxic insult to the normal anatomy of the eye. If you have loss of corneal stem cells, this can lead to vascularization of the corneal surface or just a persistent corneal epithelial defect that doesn't heal. The treatment is speedy and efficient irrigation of the eye itself. That's the number one prognostic factor in helping these patients have a good result. What you're going to want to do is give a topical anesthetic like proparacaine. You're going to want to give IV fluids sprayed onto the eye and irrigating vigorously for about 20 minutes. Then you'll wait 5 minutes, and then you're going to want to recheck the pH, and you're going to continue until it becomes neutral. The reason why you wait 5 minutes is to make sure you're getting an accurate sample of the acidic environment of the eye itself. If you check 1 minute after you stop your irrigation, you may just be sampling kind of the fluid that you're pouring into their eye. This is the pH paper. It's actually a lot simpler than it sounds. And you're going to want to take a strip off, anesthetize the eye, hold it there under the conjunctiva for about 10 seconds, and kind of match it up to the appropriate color. These are Morgan lenses. These are used in the emergency department to promote efficient irrigation. Many times in the children's hospital, we'll give the patient a relaxing medication such as intranasal Versed to help them tolerate the irrigation, because it can be a challenging process to get the kids to hold still and do it the right way. And then this photo is just shows complete corneal haze due to an alkali burn. And then we were talking about this briefly, but one of the things to keep in mind is the status of the limbus. So your limbus, which is located here between kind of your iris and your conjunctiva, it's the area where you have your corneal limbal stem cells. So in a normal eye, your cornea is being replenished by this reservoir of epithelial stem cells every 3 to 7 days. And in ophthalmology, we debate a little bit about the statistics about this, but in general, if you have up to 2 to 3 clock hours preserved of limbal stem cell function, then you're going to be fine. Your eye is able to regenerate the necessary amount of epithelial cells to kind of overcome this this type of injury. It gets trickier when you have less than 1 clock hour, less than 2 clock hours, whether or not you're going to be able to regenerate the necessary epithelial cells to heal from the defect. And if you're interested in that subject, one of the interesting things to look up would be autologous limbal stem cell transplants. So, for example, someone who has complete destruction of all their limbal stem cells in their right eye can get a tissue transplant from their left eye and have the corneal epithelial cells regenerate and end up having a good result, something that's new. So we talked about the irrigation, talked a little bit about the anatomy involved. What are you going to do after the initial kind of workup's done? You're going to want to put the patient on topical antibiotics as prophylaxis for that epithelial deficit. You're going to want to give them systemic vitamin C because that promotes proper wound healing. You'll give them doxycycline, 100 milligrams PO twice a day. Doxycycline is useful for its anti-metalloprotease qualities. It helps with the immune response to this type of injury. Essentially, your eye gets very angry and inflamed, and that aggressive and vigorous immune response can be damaging. And the doxycycline helps limit the vigorousness of that response. You're also going to consider putting them on cyclopentolate twice a day to keep the eye itself from spasming due to all the inflammation. You're going to want to follow them closely in the outpatient world for development of symblepharon. Symblepharon is just adhesions developing between the conjunctiva and the cornea. And then also you'll want to consider a corneal transplant based on the vitality of the corneal stem cells. We talked about that. Corneal trauma, let's talk about this. This is something that we've all seen. You're told about a 38-year-old white male who presents to the emergency department with chief complaint of left eye pain for the past 2 days. He endorses photophobia, frequent tearing, and blurry vision over this time period. On review, he states he feels like his pain started a few hours after using his weed eater to do yard work. You perform a slit lamp exam and drop some fluorescein in there and note the following picture. What's the best description of the situation? Please pause the video, take a look at the answers, and let me know what you think. So if you chose answer D, you chose the correct answer. He has an abrasion and should be put on moxifloxacin 4 times a day, erythromycin ointment twice a day, as well as artificial tears every 2 hours, PRN. And we'll talk a little bit more about this, distinguishing between an abrasion and an ulcer. No signs of a corneal laceration. Again, thinking of the previously talked about subject of open globe, you don't see any iris defects. You don't see a hyphema, blood in the anterior chamber. You don't see any uveal tissue prolapsing through any wounds. So that's a little bit too much of a call. You just see a superficial epithelial defect. So corneal abrasions, what are the signs and symptoms? Frequent tearing, photophobia, foreign body sensation, and blurry vision, just as our patient described. You're also going to notice on exam the patient has a red eye. They have fluorescein dye highlighting the corneal deficit under blue light. So you need to think a little bit about the anatomy of the cornea to understand kind of how to work this up. There's 5 basic layers of the cornea. You have the epithelium, you have Bowman's layer, you have stroma, which makes up the bulk of the cornea. You have Descemet's membrane, and you have the endothelium. When you're trying to distinguish whether someone has a corneal abrasion or a corneal ulcer, keep this anatomy in mind. Corneal abrasion will just affect the epithelium itself, whereas a corneal ulcer is going to be a deeper lesion, which involves Bowman's membrane. The classic history for corneal ulcers is a contact lens wearer who wears their contact lens too much and doesn't practice good contact lens hygiene. Sleeps in their contacts, doesn't wash their case as well, things of this nature. You're going to want to look out for distinguishing between a corneal ulcer and a corneal abrasion. There's a major difference. A corneal ulcer in the central visual axis can be devastating for a patient if they're not treated appropriately. Ophthalmology needs to be consulted on a corneal ulcer. To start, fortified antibiotics. They're going to be taking those drops every hour. They're also, They're also going to want to probably do a culture of the lesion itself on different plates to isolate the bug that's growing. A couple other things to consider. The treatment, you're going to want to put them on antibiotic ointment 4 times a day. You're also going to want to give them artificial tears every 2 hours. And you're going to consider giving them cyclopentolate to prevent ciliary spasm. The eye's irritated in general. If you prevent that spasm reflex, sometimes patients can have some relief from that. The pearls to remember, again, beware the ulcer if the patient has a history of wearing contacts. If they have a foreign body, that needs to be removed by an ophthalmologist at the slit lamp with a needle. That's not something you should probably do, because you can end up perforating the cornea and get into a lot more trouble than you want to. And then if you do a fluorescein stain and you appreciate this dendritic lesion, the patient has photophobia and some blurry vision, you're probably looking at a patient who has herpes simplex keratitis, which is completely different than a corneal abrasion. And that patient needs an ophthalmology consult and exam as well. They're going to need to be started on acyclovir and evaluated with a dilated exam, because sometimes patients can have very serious conditions that involve retinal necrosis and irreversible damage to the eye itself. So that concludes the presentation. I hope you've enjoyed it and learned something.